Welcome everybody to the stroke prevention webinar, which will be led by Dr. Gurmeet Singh and pharmacist Malgorzata Burton. Everybody, please, could you grab your mobile phones? We will be doing a little test. And if you go on the internet and you go and you put menti.com, I'll put it in the chat, menti.com. It will ask you to put in a code, which I will give you immediately so that you can access a little quiz to see what your level of knowledge is. Oh, excuse me. All right, so if everyone is on menti.com, please could you put the code above 2176892. I'll give you a couple of seconds to do that. How much do you know about stroke prevention? Let's start. Dr. Gurmeet, I'll let you take over. Thank you very much, everyone. Dr. Gurmeet?
Sorry. Yeah. Hello. Hi, everyone. I'm Gurmeet. I'm a GP. Nice to see a good attendance. We are just going to talk about the atrial fibrillation and stroke mainly, and also what your role could be in saving lives, with very simple means, very simple tests, and you could save lives. We need to know what the roles are. So these are all personalized care roles. Yes? Yes, Meena?
Yes, they are, absolutely.
So social prescribers, care coordinators,
GPAs.
GPAs. Yeah. Okay, good. So these are simple questions, very simple questions. And we will do them again at the end, and then you will see you've gained a wealth of knowledge suddenly. So yeah, that's fine. So 5 out of, we're still waiting for some people. Is everybody on Menti? Anybody having problems? No. Okay, so that's fine. So yeah, almost everybody knows it's atria of the heart. So that's good. Next. Don't worry about getting it right or wrong. Don't worry at all, So people can go to the next question themselves. Okay, that's fine. So let's give them a few more minutes so we see more answers. Yeah, don't bother about sort of checking on Google or anything. Just put what comes to your mind. You will know everything by the end of the talk. Don't worry. Okay. Right. Yeah. So I think, Yasmina, you will have these results for later as well, because you can scroll backward and forward, isn't it? So I think that will be fine. Okay. Next. Okay, that's great. 5, 6, 7. So I think about 8, 9 people are answering. So yeah, we've got 8, 9 here. So that's fine. Next. Okay, people don't like this. Okay, that's fine. Oh, 2 have said true. 2 people would treat patients with rat poison. That's good. Okay, next. Yeah, we've got 9 people here. Personalized care staff, true. 1 person thinks that they can't. Oh, okay. It would be interesting to know who it is, so we can sort of change their mind. Okay, that's great. Personalized care staff can save lives. 8 people think yes, 1 thinks no. Okay, that's great. Okay, that's done, isn't it? That was the last one. Okay, great. So let's move to the teaching. So apart from care coordinators, social prescribers, GPAs, any other specialty? Anyone else? Any pharmacists? No? Okay, that's fine. Okay, let's start then. So we are going to talk of atrial fibrillation, so everybody understands what it is. and how it causes stroke. Okay, next. So these are the learning objectives for today. What is atrial fibrillation? How is it linked to strokes? How can personalized care staff contribute to minimizing strokes? Basically by providing personalized care, which is your field. Which patients do we screen? Do we screen babies? Do we screen young adults? Who do we screen? And then addressing some of the alerts. I presume everybody works with EMIS, and in EMIS you get those alerts at the lower right hand side. So there are some alerts there that you could recognize related to this. And then just a basic information on what medications are used for AF. Next, please. So AF, atrial fibrillation, is the most common arrhythmia of the adults. Overall, the prevalence is 2 to 4%, but in over 80s, it is more than 10%. So this was one of the questions, wasn't it? The prevalence of AF in patients over the age of 80, that's 10%. In fact, it's about 12 to 13%, so it's quite high. 1 in 10 people will have AF over the age of 80. And it increases with age. Men are more affected than women. Okay, next. So why are we concerned? So AF causes stroke. So this is the big elephant in the room. It causes stroke. And then it also causes other conditions which you are quite familiar with. Depression in 1 in 5, heart failure in about 3 patients, 2 to 3 patients out of 10. And then the risk of death is also increased because of the complications that can happen with AF. It also over time leads to, contributes to vascular dementia, development of vascular dementia. Next. And the morbidity it causes, it leads 10 to 40% hospitalization rate in patients of AF, mainly because of heart attacks, heart failure, complications associated with treatment. And then they have impaired quality of life in more than half of the patients because of the AF burden, comorbidities, and the psychological issues we discussed before, like depression and all that. Next. And what are the risk factors? The slides looks very busy, but don't worry. I think the main thing you need to remember is, I don't know if you can see, I can't move my cursor, but you see the top ring, it's all to do with the heart, or the problems to do with the heart, valve disease, heart failure, coronary artery, vascular disease, all these are to do with the heart. That's one. And then there are lifestyle ones, the blue ones on the right hand side. Physical activity, lipid profile, alcohol, smoking, obesity. So those are the lifestyle issues. And then there are issues related to other organs of the body, which is like obstructive sleep apnea and COPD related to the chest, and then inflammatory bowel disease, inflammatory diseases, or acute illness, which are like acute episodes, and then kidney disease, diabetes, and hypertension, which are like the main sort of chronic diseases. So all these can contribute to AF. Yeah, next. Now, if we come to the basic structure of the heart, you're probably aware, but just to recap, the blue is the deoxygenated blood coming from all over the body into the heart. So it comes to the right side of the heart, and then it goes to the lungs, gets oxygenated, becomes red sort of, and comes to the left side of the heart. And then it is pumped from here. So why does AF cause a problem? Next, here it shows why AF causes a problem. So this is the normal functioning of the heart. So you see the atria, the upper chambers, they contract slightly before the lower chambers, and they fill up the lower chambers with blood quickly before the lower chambers contract. So this is called the atrial kick. And this atrial kick is responsible for about 20 to 30% of the total output of the heart. So in AF, when this kick is lost, patient could lose up to 30% of their cardiac output. And if they're already on the verge of heart failure, it could immediately precipitate catastrophic heart failure. You see? Next. So how does the heart do this conduction bit? So this is the electric wiring of the heart. As you can see, the green bits. So the impulse originates at the what is called the SA node. So again, if you could move, Yasmina, if you could move the cursor. So it originates in the SA node, and then it travels quickly across the atria using those middle internodal tract and the posterior internodal tract and the other one. And it comes to what is called the AV node. And here it is held for just a microsecond. It is held for a very short period for the atrial kick to do its job. And then the impulse quickly spreads down to the ventricles through the Purkinje fibers, the left and right bundle branches and the Purkinje fibers. Yeah, next. And when you see it in action, you can see that when the upper chambers contract, it's the first half of the ECG, the normal ECG trace that you see. The P wave, that is to do with the atria. And then the rest is to do with the ventricles. And in the lower figure, in the lower diagram, you will see that the impulse is held just for a slight period at the AV node. See? And then it spreads down quickly. So that is how the heart maintains its cardiac output. Next. And how does AF cause a problem? When there is atrial fibrillation, which means that the atria don't contract properly, the top chambers are beating irregularly, the blood is not flowing, as it should, it's swirling, stays within the atria, and this can lead to clot formation, especially in the left atrial appendage. This is the area where the clot can sit, or on the right hand side, just completely on the right, left atrial appendage. So this is where the clot can sit, and in a very few selective patients, the surgical treatment is needed to remove this left atrial appendage because clots form here. Okay, next. So what is atrial fibrillation? It's disorganized depolarization, disorganized, and it doesn't cause any contraction. It's just quivering, the atria are just quivering. And it is because of the abnormal firing, and then the impulse just goes all over the atria. It doesn't follow a normal path. So there are multiple re-entry circuits of electricity, and that causes the atria to contract, in a haphazard manner. And what causes this? So three main things. One is damage to the tissue. So the normal muscles of the heart, if they are damaged, they cannot follow the instructions that come through from the electric system. The second is a problem with the electric system itself, the wiring. So as we know, even in our houses, the wiring needs to be changed after 10, 20 years. So a person living up to the age of 80, definitely the wiring can go wrong. So that is where the problem is with the wiring, the electric circuit. So there are many sort of diagnoses. One of them is like sick sinus syndrome, where the sinus itself has a problem. And then because this is electric current, it is related to positive and negative charges, we all know. And electrolytes, metabolites, and hormones, they can all affect those electric charges. So whenever there is a problem with the electrolytes, metabolites, or hormones, the firing can be disrupted, and that can also contribute to AF. Yeah, next. Now, this is what we were talking. So, Yasmina, if you just go to the slide, you will have a video. Yeah, if you run the video. So you see the normal conduction, the normal circuit is like this. And then in atrial fibrillation, it is like re-entry everywhere and all chaos. And the atria are not actually contracting. They're just irregularly sort of quivering. Okay, that's fine. Next. Now, what are the patterns? I mean, you don't really need to know the different types of AF, but there are three: paroxysmal, persistent, and permanent. Yeah, Yasmina, go ahead. Paroxysmal, permanent, paroxysmal, and persistent. You don't need to know, but just for your information. The important thing is 50% of AF is asymptomatic. So of the 18 people present here, 9 could be having AF without any symptoms. So this was one of the questions in the Menti. 50% of patients with AF could have no symptoms at all. That is why it is so important to do the checks, to check their pulse, which is like just takes a few seconds. And it is the most important most cost-effective way of picking up AF and saving lives? Just checking their pulse, because they might have no symptoms at all. Next. So that's highlighted. That is probably, if there is one thing that you take away from the talk today, is that 50% of the patients might have AF without any symptoms, and you are just placing your hand on their pulse and checking if it is regular or irregular could save lives, you see. Next. So why is it important? Because it is a major cause of ischemic stroke, 5 times higher than in a normal person. So this was another question in Menti. How many times does it increase the risk of stroke? 5 times in patients. And then the other problems are strokes because of AF are more severe. And why treatment is so important? Because it reduces the risk massively, 65 to 70%. So we could definitely be preventing strokes by preventing AF. Next, or treating AF. Okay, what is stroke? Some of you might want to know what is stroke. So obviously it's when the brain gets damaged because it doesn't get blood supply. And there are two main methods. One is deprivation of blood supply, which happens when there is a clot, which is related to AF. So 85% of the strokes are because of this, and therefore they are related to AF. But 15% of the strokes can be caused by a bleed, which is the side effect of the treatment of stroke. Because we are giving anticoagulants, it can cause bleeds, and that can also lead to stroke. So you see the ischemic stroke is where it's gone all gray because the blood supply has been stopped, and the white is the bleeding because an artery has popped and there is bleeding in the brain. Yeah, next. And how do we spot stroke? I'm sure everybody is aware of the FAST posters everywhere. How we pick up stroke? It's calling 999 straight away because it's as important as a heart attack. And I'm sure everybody is aware of the components of FAST, but it's like you look at the face and the patient cannot smile, or their face on one side is drooping. So that could be a sign of stroke. They can't lift their arms, so there is weakness of arms, legs, or it could be any other area. But if they can't lift their arms, that's a big problem. And then their speech affected. So they might have slurry speech, or they might not be able to speak at all, or they might not be able to understand. It all depends. What symptoms they show will all depend on which area of the brain is affected because of the stroke. But these are fairly accurate. So if a patient has these issues, then definitely we need to call an ambulance. Yeah. And then there are other signs, again, depending on the area of the brain affected. It could be blurry vision, it could be memory loss, confusion, it could be headache, loss of consciousness, anything. Yeah. And the important thing to remember is stroke can happen to anyone at any age. So just don't think this is a young person, so this can't be stroke. This should be something else. It can happen at any age. Okay. Next, screening. So how do we do the screening of AF? Everybody, I assume we all can check the pulse, isn't it? The radial pulse, all the cubital pulse. We can all check the pulse. Anybody has any questions till now? Are we all okay? Any questions at all? If you raise your hands, or put something in the chat if you have any queries.
I haven't seen one in the chat as of yet.
Nothing in the chat. Any hands? Anybody wants to ask anything? No? Everything good till now? Okay, that's fine. So the normal pulse, we all know, it's a regular and it is between 60 to 100 beats per minute. In AF, the main finding is an irregular pulse. So the pulse is irregular, but it doesn't have any particular pattern of irregularity. It is irregularly irregular, if you understand what I mean. Yeah, all over the place. So there are many ways to check the pulse nowadays. The basic sort of gold standard would be patient coming to you and you feel their pulse. Just place your fingers on their wrist, radial artery, and you feel the pulse. But nowadays there are many other ways. So I've got this watch, and this can take my sort of pulse, blood pressure, whatnot, a lot of things. So there could be wearable devices, there could be smartphones, smartwatches, and the blood pressure monitors can also tell you if the pulse is irregular. The advanced ones will say irregular pulse, but the basic ones will give you an error reading. So they might not say, but if they can't read the blood pressure, one of the reasons could be irregular pulse. Okay, and studies have shown, research has shown, that opportunistic screening of atrial fibrillation by pulse is the best and the most cost-effective way of picking up atrial fibrillation. So all of us, we see a patient over 65 for any reason, just put your hands on their pulse and check that it's regular or irregular. That's all that is needed to sort of, screen for AF. And just to give you an idea of what it sounds like, the sound is very faint, so you might need to, up your volume on your monitors. But Yasmina, if you just play this, so everybody goes quiet and let's hear. It's not playing? No.
No, it's not, I'm afraid.
Okay, that's fine. Leave it then. So
Okay.
I put in a small video to show how it sounds, but it's irregularly irregular. Okay, next. So this is all about the AF and its background. From here onwards, Gosha will take over. There's a lot of information. It is just to keep you informed. You don't have to act on this. There are just a few areas where your role is important and very, very important in picking up AF and preventing strokes and saving lives. So don't underestimate your value. You can definitely save lives, and you will see how at the end of the presentation. Gosha, if you take over, and Yasmina, I will leave for my other meeting. Is that okay?
Absolutely. Thank you so much, Dr. Gamit.
Okay, thank you so much.
Hello everyone, my name is Małgorzata Burton. I'm one of the pharmacists. I'm working for North Havering PCN, and I am ARR staff as well. So it's nice to see you today. So basically, we put this presentation and diagnosis just for your general knowledge. You might come across in your practice with patients complaining some of the symptoms. Obviously, you wouldn't act on it, but you might refer on to a GP or pharmacist or a practice nurse if you recognize some of the symptoms that patient is complaining about. So some of the symptoms of AF is heart palpitations. So they can feel that they've got like an irregular heartbeats. Fatigue, which is tiredness. They might complain to you about shortness of breath, dizziness. They might feel lightheaded. They might have shortness of breath when they exercise or walk. They might complain of some chest pain, and they might have some incidence of fainting. Yasmina, would you mind just putting the next slide for me, please? Thank you. The AF might present as a stroke, as we said earlier, as Dr. Singh said earlier, heart failure, PE, or thromboembolism, due to the fact that there might be a clot in the blood that might cause that. Yasmina, thank you. The presentation at the practice is, like Dr. Singh said already, it's irregular pulse. When there's like a chest examination, the heartbeats are not regular as well. There's a possible murmur, but that's something really more advanced, so we wouldn't deal with it anyway. Yasmina? And the test to diagnose AF is just for your information, just, you don't need to remember it. So we normally refer patients for ECG or Holter monitoring and some other cardiology monitoring as well. And tests that we can do in a primary care is just like a general blood test that includes some hormonal blood test as well, ECG. We can refer for the chest X-ray and some other tests as well, stress test. Okay, next slide, Yasmina. Thank you. So in primary care, we focus on treating the AF by looking at starting anticoagulation to avoid patients from having stroke. Then B is a better symptom control, and C, that's mainly affecting us, and holistic approach. It's how we can manage other symptoms, cardiovascular and comorbidities as well. With regards to anticoagulation, we start anticoagulation in, we do like we have like a tool called CHA2DS2-VASc score, when we can predict the risk of patients having stroke, and if the CHA2DS2-VASc score comes as a 1 for female or 0 for male, then we don't start anticoagulation. When it's 1 for male and 2 for female, then we're thinking about starting a medication. With symptoms control, we mainly focus on a root control or rate control, so patients can feel better as well. And with comorbidities, we advise patients on lifestyle changes. So if the patient is obese, it's about weight reduction, motivating people to exercise more, reduction of alcohol use, smoking, and so on. Yasmina, can you just put the next slide, please? Thank you. So this is just for the information. What is a CHA2DS2-VASc score? You might come across this on IMIS system. When patients got AF, there's like a quote for CHA2DS2-VASc score as well. It might be on one of the alerts on the right-hand side. So, so patients are more at risk of having stroke if they've got congestive heart failure, they have high blood pressure, age over 75, they've got diabetes, they already had a history of stroke or mini stroke. If they have vascular disease or you know, history of heart attack, we give 1 point for patients who are at age of 65 to 74, and also the sex category as well. We give one score for female, 0 points for males. Okay, next slide, Yasmina. This is the bleeding risk scores. So this helps us to predict, you know, what risk will bring if we start the coagulation. The main one, the most recommended by NICE is ORBIT. However, on the IMIS system, you can come across half blood. So with regards to ORBIT, we're looking at patient's age. So older the age, you know, there is more risk of having bleeding. If they had reduced hemoglobin, if there's a bleeding history, reduced kidney function, and also other treatments with blood thinning drugs, that's putting patients more at risk of having bleeding. So we need to look at that and discuss it with patients as well. Okay. Thank you, Yasmina. So with the stroke prevention, like I said, we're looking at the CHA2DS2-VASc score. If it's 0, we don't do anything if patients got AF. If it's 1 and it's a male, we normally discuss that there is a possibility that they might be at risk of stroke, and you know, we discuss it with patients if they would like to start anticoagulation. And with CHA2DS2-VASc score 2 and more, we recommend starting anticoagulation medication. Okay, next slide. Yeah, so like I said, and bleeding risk scores, as I mentioned, ORBIT score, if it comes, you know, the score comes between 0 and 2, that's a low risk of bleeding. So normally it's quite safe to go ahead and start anticoagulation. Intermediate risk is around 3, and high risk of bleeding is 4. And you know, whereas the higher the risk of bleeding, you know, the more you need to inform patients what are the risks of starting anticoagulation, and you know, just make patients aware as well that, you know, it's good to prevent the stroke. However, there's risks of having anticoagulation as well. Okay. So this is the medication that we normally start for patients who's got AF. It's a vitamin K antagonist, which is a warfarin. Normally it's started at a secondary care. Then we've got DOACs, which is direct oral anticoagulants. You might come across on the patient's record with the name of the medication like dabigatran, apixaban, edoxaban, and there's another one, rivaroxaban. Some patients are on heparins. However, that would be mainly if they are under the secondary care or they've got recommendation to be on this medication via secondary care. So it's not very common. Okay, next one. So yes, anticoagulation should be offered with Charles-Bach score is 2 or more because the risk of having a stroke is higher. As a first line in primary care, we offer NOAC, or you can call them DOACs as well, which is the oral anticoagulation. I've mentioned the main names already. The medication names is apixaban, edoxaban, rivaroxaban, dabigatran, and warfarin mentioned already as well. Okay. With the medication, when you see patients, for your consultations, they might mention some of the side effects of their medication, and if you recognize there's something going on and you're not too sure if it might be due to the medication, you can refer on to pharmacist or a GP or a nurse. The main risk factor with the anticoagulation is bleeding. With the dabigatran, they might complain also about the side effects with the GI, so like some indigestion, diarrhea, weakness. With other anticoagulants, they might complain of having like a bleeding gums, nasal bleeds. They can bruise easily. They might have some loss of appetite, nausea, dry mouth, constipation. If you're not sure, then just refer on if patients complains about any of those. Okay, thank you, Mina. With regards to DOAC monitoring, I'm not sure if you're involved in ordering the blood test. Some of care coordinators work with pharmacists and GPs, and they do some of the work. It's just for your information that patients should have monitored renal function at least once a year, a full blood count, LFTs, and it's good to record weight as well, just to monitor medication. Then we run, we've got like a template on IMIDs. We calculate creatinine clearance, which takes under account their renal function and their weight. And if the creatinine clearance is between 30 and 60, we recommend to do blood 6 monthly. And if the kidney function is more reduced, then we recommend blood test 3 monthly. Okay, Yasmina, can you just put the next slide? With the warfarin, so it's like a more conservative anticoagulant. It's been around for many years. The good thing about a warfarin, if it's elderly patients, they need regular monitoring. They would have to go to the pharmacy and have their bloods done quite often. So for the elderly patients, warfarin, sometimes it's a good thing because they can go out, they can meet people at the pharmacy or at the hospital setting, they can chat to people as well. So that's one of the things about the warfarin. Some people, like that. Some people don't like that. That's why they are on the DOACs. Yasmina, can you just put the next slide? So also one of the wanted to mention with regards to INR, you might see alerts as well on the right-hand side that patients who are on a warfarin, they need like an INR monitoring. We can record it on IMIS as well. And some patients just struggle. They don't want to see someone every week or every 2 weeks or every 3 months for the blood test. The dose of warfarin might change. It needs to be adjusted. Sometimes it needs to be adjusted because of the diet as well. So if they've got a lot of leafy green vegetables, warfarin dose might need adjusting as well. And they need to, look at the diet as well. With regards to the BNOW, better symptoms control, we're talking about the rate control, which is for every patient. We're looking like what is their pulse rate. The medication they might be on that you might see on a patient's record is bisoprolol, digoxin, diltiazem, and verapamil. And with regards to the pulse, when you see patients check their pulse, and sometimes you just look at the rate. The rate normally depends on cardiologist advice as well. The rate should be between 110. If it's more strict control, below 80. With regards to rhythm control, that's normally recommended by secondary care. It's recommended for symptomatic patients who's got like a fainting, dizziness, they don't feel well, they've got heart palpitations. The medication that you might come across is amiodarone or dronedarone. Other treatment is hospital treatment with cardioversion and left atrial ablation, and that is in secondary care. Okay, next slide. And this is more for you guys with regards what can we do during the consultations as care coordinators, as a health and well-being coach. Look at the risk factors that we can modify. Yasmin, can I have just the next slide? So sorry, the back one. Thank you. So we can look and screen patients for alcohol use. We can screen them for the blood pressure. We can talk to them about weight control, about diet, smoking as well. So that's one of the things that we can discuss with patients during the consultations. Yeah, thank you. So we're reviewing the patients who started medication as well. We've got a telephone review after we're starting the medication to see how they get on. You can also be involved in it, and you can ask some questions, asking them, what do you know about AF? Do you know that the anticoagulation is not for your heart, it's just to prevent you from having stroke? You can ask some questions as well, how are you getting on with your medication? Have you started taking it yet? Do you understand that it's anticoagulant and how it works? Do you have any problems with your medication? Did you have any episodes of bleeding? Do you have any side effects, any problems at all, any concerns? And if they say yes, I'm not sure about this, then obviously you can refer on as well. Okay, next slide, Yasmina, thank you. With regards to reviews, when you're seeing patients, so I've just said about a few things about that. So I think it's just the same slide. How can I contribute to minimizing stroke risk in AF? So as a team and multidisciplinary team, obviously we want to treat patients in a holistic and centered approach way. So obviously first thing would be, finding out what are the patient's goals, what matters to the patient, what are their concerns. With regards to treatment optimization and improving their lifestyle, I think you're well aware of motivational interviewing, asking them, what they would like to achieve, and then how would you like to achieve it? So spending time with patients, building good report as well. You can help by referring on to different different professionals like care coordinators, social prescribers, health and well-being coaches for patients to be more motivated. If they are dealing with depression or they have low mood, we can refer to mental health practitioners. If we identifying that they've got falls and they might need some OT assessment, we can refer to social prescriber. For the medication review, we can refer to pharmacists and nurses. Yeah, next slide, Yasmina, thank you. We can help with medicine safety, so we can remind patients of having a blood test. There's like a little alert as well on a screen that pops out, or you due for blood test. So we can remind them about the blood test. If you're not sure how to order the blood test, you can tell them go to the reception, and the reception team will work with you on that. You can check their weight, body weight. If you see that there's no body weight recorded on the EMIS record for a while, you can take this opportunistic approach and just check their weight and record it on EMIS. You can support patients with care after hospital discharge as well. They quite often, got a low mood. They're a bit overwhelmed after being discharged from a hospital and having new diagnosis of a heart failure or AF, we can just see how we can support them as well. We can signpost patients to written resources. So it's either at the surgery, we can send them letters, or we can send them AQRX messages with some more information. The main thing is just, to help patients to help understand their condition, how they can manage their condition themselves, and when to seek for help and who to ask as well. Okay, next slide, please, Yasmina. And with regards to addressing some screen alerts, I just put some of them here. I wasn't able to, to get all of them, but that's quite common. What you can see on the right-hand side, if you see that the blood test is due, you can just prompt patient apixaban monitoring advice. So this is normally for like for a DOAC monitoring. So that's like alert for a blood test and weight check as well. You can also see the anticoagulation advisor, and sometimes when you go on it, it just gives you a patient's Chadwick score and Hasbred score as well. So you can see, if they're at high risk of having strokes, if they're at high risk of having bleeding as well. Okay. And like Dr. Singh mentioned as well, don't forget to check their pulse. Yeah, this slide is just to show you how we can roll as a how we can work as a multidisciplinary team, how we can support patients in a holistic way. There's like a important that it's very important to give patients psychological support. Support them with lifestyle modification, education, to be there when they need us, basically. So this is how we can all optimize stroke prevention and patients treatment. So yeah, so I think, is there any more, Yasmina? Yeah, so do you have any questions at all regarding AF or medication, or would you like to go through like some slides again? How do you feel more confident about AF now, and you've got better idea of how you can prevent and how you can help patients with AF?
There's also the test they need to. We have a pop quiz for you to make sure that you've been listening the whole way through. For those of you who arrived a bit later, we've used something called menti.com. So I put it in the chat earlier, menti.com, and you just need to put the code on the slides that I share with you. You'll see it at the top. So I'm just going to share it now. That way you can answer as we go along. So a lot of you have answered already. So far, we have only 2 answers. I'll give you some time to answer. So get on menti.com, and then you just put the number at the top, 217689 and 2, to access the slides. So far, we have 6 answers. Are they correct, Gosha?
Yes, they are correct. Well
Oh,
done.
good. Okay, good.
Yes, that's right.
That's okay as well. Great. Okay, well, I think now because Gosha has said it, everyone's going for that one. So
Found it.
yeah. Should go to the next one. So let's give it a bit of time so everyone can have the opportunity to answer. What do you think, Gosha?
So yeah, so 50% of patients who's got AF, they don't have any symptoms.
Wonderful.
So most of you
Ooh.
the right answer. Yeah, so
Quite a few variable answers. What do you think, Gosha?
so AF increases the risk of stroke by 5-fold in this. So most of you, yeah.
Most of you got it right. Well done.
Yes, that's right. Yes, everyone was listening.
Yeah, and the reason why the rat poison question was asked earlier is because, and I didn't know this, warfarin is a form of rat poison, isn't it?
Yeah, it was.
Wow.
Yeah, it used to be used as a rat poison, warfarin. Yeah, I don't think it's just got much use at the moment, like now.
No.
But yeah, it's historically warfarin. So you might come across patients saying that I don't want a warfarin because it's a rat poison. And you know, it's got like a bad press as well in elderly people. So yeah, so just be aware of that. Yes, well done. That's really good.
That's definitely the most important question.
Yes,
Glad
that's
everybody got it right.
important. Yes, everyone can take part in
Yes.
saving lives.
Exactly. And I believe, great, that was the end.
Yeah.
Thank you very much, everybody, for coming and participating in the webinar. If you do have any questions, please do ask them. Before you go, please, before you go, whilst you think of your questions, I'm just going to put in the Zoom chat the document, the link where you can access the survey to give us feedback on what you thought about this webinar. It's very important for us to know if this was helpful to you in any way, or if you feel that you would like to tell us how we can improve for future webinars, we will take this on board. There's a message. Thank you, Tanya. Lovely to see you again. Please don't go. Please don't go. I'm going to put give me one moment. In the meantime, please don't hesitate to ask any questions. Okay. Thank you, Karen. Thank you for coming. Thank you, Mary. Thank you, Vera. Thank you so much for all your comments. Please do leave them on the survey. I put the link in there. No problem, Maria. No problem. I will stop recording.